Good morning, everyone. I am CWRU alum, Dr. Karen Hogan, class of 1983, and I serve as the Alumni Association Board President of the Francis Payne Bolton School of Nursing. I'm delighted to welcome you to our Health Sciences Collaborative event today. This annual homecoming event exemplifies our ongoing commitment to collaboration between the health sciences at Case Western Reserve University. I would like to acknowledge our Dean, Dean Chance of the School of Dental Medicine. There he is. Thank you. Thank you for coming. I don't see any other deans, am I correct? Okay. All right. We are here at the Health Education Campus where students from the health science schools, Francis Payne Bolton School of Nursing, the School of Dental Medicine, and the School of Medicine, come together to prepare for team-based healthcare careers. This state-of-the-art facility embodies the collaboration that is at the heart of what we do, fostering interaction among our schools and our disciplines. Our topic this morning, the role of healthcare providers in the age of artificial intelligence, addresses the intersection of AI innovation and technology with the art of healing. We are privileged to have three distinguished alumni who are leaders in their fields and will share their perspectives into the impact of AI in dentistry, medicine, and nursing. To begin our session, Henrietta will introduce our first panelist.
Good morning, everyone. My name is Henriette. I am a fourth-year dental student here at Case, and I hope you guys are having the best homecoming weekend yet. I'm here to introduce Dr. Jed Best, a clinical professor at Case Western Reserve University School of Dental Medicine with additional academic appointments at Columbia University and the University of Alabama at Birmingham. Dr. Best has earned his DDS from the Case Western Reserve University and his MS from the University of Minnesota. A past president of the College of Diplomats of the American Boards of Pediatric Dentists, Dr. Best is also a section editor for the Journal of Pediatric Dentistry. He is board certified in pediatric dentistry and a fellow of both the American and International College of Dentists. It is my pleasure to introduce to you this morning Dr. Best. Welcome, Dr. Best.
This slide dates me. Oh, wait, I gotta turn this back on, sorry. Some things to know about being a dentist, and particularly being a pediatric dentist, which I gladly have been for over 40 some odd years. We love shining objects. Doesn't make a difference what they are, we love them. We also love technology, whether it's a waste of our money or not, whether we can use it or not, we buy it. Dentists just love toys. Porsche dealers love dentists because we love toys, and Porsche's a toy. So the role of AI in dentistry is becoming very interesting. The first thing you need to know is that dentistry as a profession is probably somewhere between 5 and 10 years behind medicine. I'm going to highlight that at the end of the slides because there's a statistic that you should know about that, to me, as a practitioner and as an educator, is really frightening. But at the moment, the thing to know is the fact that companies that have been supplying AI companies with data are now in revolt. This is an article published in the New York Times, July 2024, where companies are now saying we are no longer going to supply data to companies. And if we are going to supply you data, we either going to be paid for it or we're coming out with our own AI software. Interestingly, they quoted a study that 14,000 web domains, that 3 of the commonly used AI training centers discovered that there's this crisis and the fact that the data is drying up. And if the Times is publishing it, it's probably true. Being a New Yorker, obviously, I favor the New York Times. But what's more important is the fact that there's now becoming resistance to these companies scooping up all this data, they making the profit, and the providers of the data making nothing. Something to remember. Now, interestingly, in 2022, the ADA published a white paper called The Overview of Artificial and Augmented Intelligence Uses in Dentistry. I emphasize the word augmented. You're going to see why in a few minutes. Also remember that this was published roughly 2 years ago. I assume as an audience you know what a 510K is and what a PMA is. So just put that in the back of your head for a few minutes. So a young dentist, as opposed to a skeptic like myself, has two choices when AI software comes out. And you should all know that AI software for dentistry for the diagnosis of decay is now commercially available. You can buy it. And it's roughly somewhere, it ranges somewhere from $200 to $600 a month. So it's not cheap. So in my life and the colleagues that I know, we would work on the bottom modality. We would diagnose the decay or not, then we might want to get confirmation from the AI software. The younger practitioners, because they're so used to using electronic toys, are going to go straight to the top. They don't use their eyes, and they don't use their brain. They look at a computer monitor. Just go to any restaurant in the United States and watch them text each other while they're at the same table, right? They don't talk to each other, they text. Hopefully not in the car, but they text. And then the question is, if the AI tells you that there's decay, is there really decay? Or is it just a radiolucency? Or is it just arrested decay that doesn't need treatment? So this is also from the ADA white paper. Currently, none of the existing dental imaging systems can differentiate between active and arrested decay, none of them. So my prediction at the moment, as a cynic, and as someone who's concerned about this influx of technology, is what's going to wind up happening is the young practitioners are going to wind up overtreating kids, and that's my area of specialty, and they won't find out about it until the insurance companies look at their profiles and see that they're charging for fillings far more than they had in the past. Then all of a sudden the alarm bells are going to go off. There's also concern about the size of the data sets. So we're all in healthcare. Could you imagine making treatment decisions based on a study of only 600 people? That's what's going on. We're not talking about thousands and thousands of films being diagnosed as validation sets. We're talking about under 1,000, and I'm going to show you some statistics in a few minutes. The other problem is, who's determining whether there's decay on the validation sets? You're going to see in a few minutes that most of the work's done by GPs, general practitioners. Nothing against general practitioners. But there are studies, and I'm going to show you one, that says that your ability to diagnose decay is based on your experience. Well, if these software companies are using someone 3 years out of school versus someone who's been out of school for 20 years, their ability to diagnose decay is dramatically different. And in pediatric dentistry, primary teeth, the contacts between each other is very different than it is on a permanent tooth. In fact, there are 3 separate types of contacts that's been documented that occur in primary teeth. GPs don't know this. The literature is not in the general practice literature. It's in the pediatric dental literature. There's also a lack of transparency. You're going to see that also in a minute in their 510K applications. And finally, there's no standardization. So at the moment, dentistry has 2 types of films, right? We have hard, old-fashioned films, E-speed, F-speed, and D-speed film, usually made by Kodak in the United States. And now we have digital x-rays. There are 3 types of digital x-rays, which people don't realize. There are phosphor plates, there are CMOS sensors, and there are CCD sensors. Most cameras that you buy nowadays, they're CMOS sensors. Phosphor plates are inherently have more artifacts and are dirtier, if you will, than CMOS sensors or CCD sensors. None of their 510K applications talk about how to filter out the noise. And in addition, if the images are more dirty or artifacty, that means you need a greater data set. And yet they're not doing it. So this is what's happening in dentistry. We're at the moment at the peak of inflated expectations. And what I fear is what's going to happen next. And my assumption is the trough of disillusionment is going to come when the insurance companies start getting involved and seeing all the work that doesn't need to be done, but that's being done. There's some other studies going on that don't involve AI where there's new ways to identify decay by using staining and dyes. They're very sensitive. The problem is they're not specific. So you can say, yes, the person might be at risk, but you don't know where because they haven't developed the technology to be specific. So as long as clinicians are responsible for diagnosis and treatment planning, they must, that's why it's in red, guard against becoming over-reliant on machine learning. I will contend, unfortunately, that the younger generation who grew up with iPhones and Androids and video games are overly dependent. They're also much more comfortable than I am. My daughter's a teacher. If I want to learn something on a computer, I just ask her. It's a lot faster than trying to study for it. Well, that also means that I'm so over-relying on this, I'm going to wind up assuming it's telling me the truth because I'm not thinking. Now, how much data do you need? As I said before, tons of approvals are coming on data that's extremely small. So this is an example of learning with small data sets. In dentistry at the moment, most of the data sets are between 500 and 5,000 samples, mostly under 2,000. I'm going to show you in a minute that they're mostly under 1,000. But the quality and the accuracy, that's the problem. If you access the raw data, and if there's a lot of noise, like I just said, and you have incorrect information, you need more data to compensate. But they're not getting it. I'm going to show you in a few minutes the 510K applications of 3 of the leading companies selling software to dentists in the United States. My wife's a lawyer, so without her telling me, I wiped out all their names so they can't come after me. Because they're not going to like what I want to say, what I'm going to say. So this comes from a journal called Neurocomputing. All of the journals and articles I'm going to show you are usually no older than 2017 to 2023. I'll usually have the dates written so you can get a sense of where we're going with all of this. So this did a review of deep learning in dentistry. The first thing to note is it's not a dental journal. Dentists will never see this. So they did a review of all of the data sets that are available and all the software. It's 2 pages long. So the first is 7 out of the 28 were over 1,000 samples. Only 7. Page 2, 6 out of 9. A third of them were over 1,000. 2/3 of these studies only had a study sample of under 1,000. And what really freaks me out as a pediatric dentist, bite wings in dentistry is the gold standard to determine whether a child or an adult has interproximal decay. Only 2 out of 37 studied bite wings. This is a journal that dentists will see. The usefulness, safety, and generalizability should be demonstrated with using more rigorous, replicable, and comparable methodology. It doesn't exist. There's no standard, none. Zippo, nada. I assume, well, I don't assume, let me explain. There's the ISO standards. In the United States, the ADA has been commissioned by ANSI, which is a subdivision of the ISO standard, to determine and deliver the standards for dentistry in the United States. So ANSI is the American National Standards Institute. They have given the ADA the responsibility of creating standards. Keep that in the back of your head for a minute. 2022, 978 phosphor plates. And what they emphasize is it should not be the sole determinant. It's supposed to assist the dentist. Now, imagine you have a young dental student. The average debt structure of someone graduating dental school in the United States now is roughly $450,000. It's expensive. Pales in what it costs to build an office. I know, I built one. But still, 450 grand. So where are these students going? They're not opening up offices because it's too expensive. They're working for the dental version of HMOs, which are called DSOs. It's corporate dentistry. Corporate dentistry wants to make a profit. God bless America, capitalism is great. But they're going to have pressure to perform. They're not going to necessarily have the time to sit and think what that lesion looks like on an x-ray. Is it arrested decay or is it active decay? The x-ray doesn't tell you. Software can't tell you that. Your brain has to tell you that. You have to take a thorough history of the patient. You have to look at the entire tooth, hopefully with magnifying glasses to see whether there's any decalcification elsewhere in the mouth. If you rely on technology, technology can burn you. So here is a data set that's almost 4,000. This is a dental journal, but they're telling you that their ability to diagnose small lesions is impaired. Well, the whole point, you don't need AI software to tell you the kid's got a big cavity. You can see it with your bloody eyes. But you really want to know whether or not it's a small cavity, and they're already telling you that the x-ray can't do it yet. And go back to the fact that the x-rays can't tell you whether that decay is arrested or not. If it's arrested, it means it's not progressing. You don't restore it. The standard of care is if dental decay is in the enamel, you don't restore. You try to do what's called remineralize. This software doesn't tell you that. This software is telling you go ahead and fill it because it's a cavity. This is from the Journal of Prosthetic Dentistry. Same thing. Tooth overlap in bite wing radiographs significantly affect the precision and trueness of AI detection. Now, I will say I'm biased, but Case, I think, is one of the best dental schools in the United States in producing clinical dentists. I went here, so of course it is. But the truth of the matter is that the software doesn't make any compensation for that. Most dentists don't use something what's called a RIN kit, which is a way of aiming the nose cone of your x-ray head to be far more accurate. Why? It takes more time. Again, a larger study, almost 3,000 films used. No mention of whether it's a phosphor plate, a CMOS sensor, or a CCD sensor. They're qualitatively different. Yet, as I've highlighted, the software is out already. Intraoral dental radiographs frequently have poor imaging. Healthcare analysis. No dentist ever reads these journals. I always laugh because in this day and age, when we sit and have section editor meetings for our professional journal, they talk about open access so that people don't have to necessarily have the journal. They can find it on PubMed without an account or without an academic account. And I just laugh. I go, they don't read the journal. They call their friends up. Well, there's a group in pediatric dentistry called IPEDO, which literally is a Facebook group for people with pediatric dentistry. It's a bitching software. You know, you can bitch to each other, I had a bad patient. But they'll also ask their colleagues questions. How do you do this? How do you do that? How do you know your colleague knows what they're doing? You don't. So in summary, before I go to part 2 of this, is what's the problems? Well, one is the articles aren't in dental journals. So dentists aren't, even if they do read it, they're not going to see it. There's no discussion of contrast enhancement on the x-rays. There's no standardization of the x-rays. The ability to diagnose incipient lesions is poor with these data sets. Most of the data sets, excuse me, don't use x-rays. Bite wings. They use panoramic x-rays, they use cephalometric x-rays, they use periapical x-rays. But they don't use bite wings. And I can't explain why. I assume over time this will change. But the software is available now. So I always thought I found this slide interesting as I ponder the state of, when I was putting this presentation together and I was pondering, this is Essex, England. But you're looking at the whole universe of what dentistry represents in terms of private practice. This is an advertisement from one of the companies selling the software. I spoke to the chief science officer of this company. The name's been removed. But superior data, what the hell does that mean? I don't know what superior data means. There's no definition. Trained on the world's largest collection of expertly annotated, curated radiographs. Not true. I'm going to show you their 510K application. And in addition, they talk about your return of investment. When I was a student at Case Dental School, one of the things I was taught was, If the company's advertising that you can make more money, be aware, be wary. That's not the reason why you're in dentistry. That's not why you're buying software or hardware. You're there to provide a better service. This, to me, is a red flag. And this is the scary part. That white paper I told you about came out in 2022. The window for commenting on the creation of an ISO standard by the AD just closed last month, the end of September. There is no ISO standard for AI-driven X-rays in dentistry. Doesn't exist yet. It's not been published. So let's talk about the 510K applications of these companies. So this is one that took 28 dentists. This is the company that told me they have huge data set. 330 bite wound radiographs per group, 660 X-rays. The baseline was developed by 3 GP dentists. Only if there is no agreement will it go to an oral radiologist to determine. This is being sold now. Second one, both devices not intended to replace complete review, clinical judgment of clinician. Obviously, a lawyer wrote this. I'm married to a lawyer. You know, I always find it funny. Pediatric dentists, by definition, you could have 1 millimeter of water in the cup, and the cup is full. Lawyer, cup could be 99.9% full, and the cup's empty. Trust me, lots of fights in my house over that. Another 510K. The results were compared to a consensus reference standard established by 3 GPs. This is the pedo software. Note, no pediatric dentists reviewed these X-rays. None. How were the GPs trained? This is a very good dental school. Trust me, there are dental schools that aren't so good. I was flabbergasted. We just did the interviews for the residents for CASE a couple of weeks ago, and in CASE, the amount of experience you could have in pediatric dentistry was vast. And some of the schools that you think or are listed as one of the best dental schools in the country, those students had 2 weeks of rotation in pediatric dentistry. 2. I spent a year. And what's the experience of these GPs? Are they just out of school? Have they been practicing like someone like me for over 40 years? Well, lo and behold, in 2017, practice experience is a key for identifying caries. How much is necessary? We don't know. And when the companies apply for their 510K, they don't say what kind of experience the dentist had. We don't even know if the dentist was trained in the US. They could be licensed in the US, but not necessarily trained in the US. So to summarize really briefly, is it time for me to worry about AI in dentistry? And their answer is, you're damn right it is. 5 to 10 years from now, hopefully not, but right now, it is. And any patient that goes into a dentist's office and that markets the fact that they have AI-driven, and if that was a friend of mine, I'm telling that patient, go get another opinion. So thank you very much for your time. I'm sorry? Oh, yeah.
Hello, everyone. I'm hoping you're having a good weekend. I'm introducing Dr. Anil Parwani. He is a professor of pathology and biomedical informatics at The Ohio State University.
The Ohio State.
I won't get it wrong. He graduated from the Case Western Reserve University School of Medicine, class of 1999. He serves as a Donald A. Seinhauser Chair of Department of Pathology and Chief of Pathology Services for the health system. Dr. Parwani has expertise in surgical pathology, pathology informatics, whole slide imaging, telepathology, image analysis, artificial intelligence, and lab automation. He has authored over 400 peer-reviewed articles in major scientific journals and several books and book chapters. Dr. Parwani has served on the board of directors, education committee, and abstract committee for the USCAP and was the president of Digital Pathology Association. He has also served on several committees, including the AI committee for the CAP, and he is the editor-in-chief of the of Diagnostic Pathology and co-editor of the Journal of Pathology Informatics. Everyone, please join me in welcoming Dr. Parwani.
Thank you so much for the invitation to speak, and I'm glad to be back at Case Western with my colleagues and friends. So the game is about to start, but it's not in Columbus, it's in Chicago. My son is going to be at the game. So I want to just give you an overview of where pathology is. And today, like when I was a medical student here, we had to bring a microscope and we had to learn histology, and so we've come a long way from there. So I want to talk to you about digital pathology and AI. I want to talk to you about what are the applications that are ready for prime time. What are the applications which are ready today that pathologists can use and make an impact on patient care? And where is this field going? So there are many challenges in pathology today. There is a lot of manual processes. We still have a lot of subjectivity, but we've come a long way. And the most exciting thing to me today is all this data which is coming from the labs. Pathology, radiology, all the health sciences combined, greater than 80% of the data which goes into the patient's medical record. So these pipelines of data, the knowledge, it's creating the knowledge age for precision pathology, and it's enabling clinical decision-making support. So from a microscope, when you put a glass slide, what can we do? What more can we do with that glass slide? So once it's digitized and it's converted into pixels, we can make more impact on the diagnosis and the predictions of the patient. So how many medical students in the room? How many of you are going into pathology? 0. So in my class, there were at least five medical students who went into pathology. So just to put things in perspective, how many, I'm going to do a multiple choice. We have 650 residency slots in pathology, approximately, give or take. What percentage of US medical graduates are going into pathology? Is it 5%, 10%, 30%, or 40%? Yeah, so less than 5%. So almost 40% of the slots are open, and they are being filled by graduates from other countries. So when I was a medical student, there were only 5. There was a lot at the time, right? So primary care was. So in general, what are the challenges in pathology today? We have still a lot of manual processes. There are some countries in the world where there is one pathologist per million patients. So think about that perspective. Pathologists, if you ask them, any pathologists in the room? Do you have a lot of time? Are you overworked? Do you have? So I asked pathologists, are you overworked? And they said, I'm burnt out. I want to come to Cleveland and work here. There is an explosion of medical knowledge, right? So when I was a resident in pathology, I knew about 5 kidney tumors, renal cell carcinoma, clear cell type. But today there are over 100 different kidney tumors, just in kidney. And many of them are molecularly defined. And we spend a lot of time on time-consuming tasks, right? Counting cells. So what if we took the microscope and we were able to digitize the slides and view them on a monitor just like radiologist? Any radiologists in the room? You love it, right?
Love it, but I've been happily retired.
But if you were a pathologist and I could tell you, you could do the same thing as a radiologist, that might have changed your mind back then. So today we have an ability to convert a glass slide into digital images, which are of diagnostic quality. So 10, 15 years ago, when I started thinking about this was a question, are these diagnostic quality images? But several of these scanning machines, which have a microscope inside them, are now approved by the FDA for clinical use. So I am a GU pathologist. I look at prostate biopsies. If I want to look inside this cell and I want to see nucleoli, I can easily see that. So it's clearly no longer a question, are these diagnostic quality or not? So this is the scanning lab at Ohio State, who's about to start a game. And these machines have microscopes inside them, but they are far away from the pathologist's offices. So pathologists are no longer tied to the microscope. They are just as cool as a radiologist. So if you want to come back from your retirement, you can come to Columbus and work here. So I'm going to show you, so this is during COVID. We had pathologists who were signing out remotely, but they were still able to communicate with residents and medical students during this process. This is a glass slide which has been converted into a digital image, and hundreds of people can review the same image at the same time and collaborate. So overall, the engagement of pathologists continues to increase. So you can see from COVID time and today, multiple pathologists are already signing out digitally. They don't need the microscope anymore. And on a given day, about 80% of the pathologists are online, and they're connected to each other. So just as an example, this is a baby microscope which allows you to digitize your slide. This is your microscope that you might have used in medical school. This has been converted into a digital personal microscope. So scan slides. So when even if I am in Cleveland today, I can review all my images from patients remotely, and I can take care of patients remotely. So this is one of my favorite images. Where are we? Yeah. So I showed this in Bangkok on Wednesday, and nobody in the audience could guess that. What's up with that? This is an iconic image of Cleveland. Everybody should recognize it. So just to summarize things, as we think about how is AI impacting pathology, we are able to now not guesstimate a biomarker. So a patient with breast cancer who has a severe form of breast cancer is dependent on therapy which will be dictated by what biomarkers are positive. We can quantitate this easily, right? So if I showed all of you this image and I asked you to count the number of orange dots, and you only have 3 seconds, all of you will have a different answer. But with AI, I can analyze a 2 millimeter square area within 28 seconds, and the answer will be the same in Cleveland, New Orleans, or in Houston. So patients with breast cancer or colon cancer, they have metastatic disease in lymph nodes. So this is an example of an AI algorithm which can assess the lymph nodes before the pathologist even comes to the office and circle the tumors which are suspicious, lymph nodes which have cancer in them. And you might say, if you're a pathologist, why do I need this? I can just look at it. What if this was a tumor which was so small, like this focus of 3 cancer cells, and AI is able to highlight it and look at it in real time. And not only can it identify the cancer, but it can give you a prediction that this is colon cancer versus esophageal cancer or endometrial cancer. So today, AI algorithms can do exactly that. They can provide that prediction. So this is prostate cancer. So I'm going to use an AI algorithm to identify cancer before the pathologist has even reviewed it. So if you're a pathologist or a medical student or a resident, this is a great tool, and you can use it as much as you want, but these are now FDA approved. The first one has been FDA approved now for primary diagnosis, so helping the pathologist in their workflow. This is a patient with breast cancer, and I can turn on a button and find the red areas where the cancer is without even a pathologist looking at it. So this could be used to pre-screen your case. This could be used during your diagnosis and so on. So as a pathologist, we are often asked to count mitoses in cancers, in sarcomas. So this is an AI algorithm which is identifying the mitotic figures, but it's not classifying them. It's allowing the pathologist to help. It's a helper tool for pathologists. So more things that are coming in the future are, these are slides that were stained in the histology lab. You can see, these are kidneys tissue sections. So I'll do a quiz for all of you. You have to identify the structures in this. Anybody, Vijay and the Boris, who were my colleagues from class of from 99, we were in the same cadaver group. So I'm going to ask them, identify these structures. What is this structure, Vijay? This is yeah. This is so the point is, this is images from a histology lab. These are images that were generated by AI. And if anybody can claim they can distinguish the two, I'm going to buy you lunch. And it's free. And it's next door. So the other things that are coming into pathology is radiology and pathology are starting to converge. So this is an example of 3D pathology. So what you're looking at here is a cancer core, prostate core from a patient with prostate cancer. And it's a benign, this is a benign core. And using AI, we can predict how much cancer is there, what grade is it, what stage is it. So we talked about AI, we talked about chatbots. So imagine a world where a pathologist who is in Altoona, Pennsylvania, and has this image, and they want to know what this is. They want to know which test to order. They can open a chatbot, and they can get a prediction of what the cancer is. So this is a patient with a skin disease, and you can now see the chatbot can offer a differential diagnosis and offer some recommended immunostains that you could do, and even recommend other features. And this is great for medical students, this is great for residents, but it's also great for that pathologist who is in a solo practitioner and help them in their practice. So this is not my office in Columbus, but it's possible to think about this as apps that you can buy on your phone and add them onto your monitors, right? So a pathologist can add apps for biomarker classification or sequencing or molecular diagnostics. So overall, pathologists can use AI today, and this is true for medicine in general, to assess them, augment their diagnosis, or it could be a totally autonomous experience. So overall, how will digital pathology and AI help pathologists? As I mentioned, there is a decline in the number of available pathologists. So all of you medical students, you need to go into pathology. We have increasing workloads, and are we ready for a digital disruption? And clearly, there are things that we can do today with AI that we could not do before. So, in conclusions, we have really amazing tools which are already here, but they need to be validated, they need to be used safely. As we heard from our previous talk, there is a lot of hype about AI. So we have to balance it with what is available today and what might be coming tomorrow. So with this, I'm going to end my talk, and thank you so much.
Hello again. It is my pleasure today to introduce Dr. Andrew Reimer, who is not only a double alum of the Frances Payne Barton School of Nursing here at Case Western Reserve University, but also a valued faculty member. Dr. Reimer's teaching interests reflect his diverse expertise in critical areas of nursing practice. He has a particular focus on critical care nursing, flight nursing, health services utilization, and informatics. In addition to his teaching, Dr. Reimer's research interest centers on big data in health informatics and simulation training. Dr. Reimer is a published researcher and has been recognized for his outstanding contributions to the field. In 2022, he was inducted as a Fellow of the American Academy of Nursing, one of the highest honors in the profession. Today, we are fortunate to hear from Dr. Reimer's insights on a topic that is increasingly critical in modern healthcare, and that is artificial intelligence in healthcare. Please join me in welcoming Dr. Andrew Reimer to the podium.
Can you hear me? Good morning, everyone. I'm happy to be here today, as mentioned, as both a double alum and current faculty of the School of Nursing. And I'm going to talk in the next few minutes here, meandering down a completely different path of what we've kind of been exposed to already this morning. Anyone recognize this picture? Not to build on my colleague's presentation, but yeah. So this is a picture from my flying office at about 2,000 feet, flying across downtown on a clear summer night. And it reminds me of a patient trip that I'll never forget. My partner and I were paged to transfer a female patient in her 70s that was experiencing a significant subarachnoid hemorrhage or brain bleed. So we flew out to a small community hospital. These trips are very time sensitive. We move very quickly. Sometimes we're at bedside for less than 5 minutes. We need to bring them back, particularly for surgical intervention if it's indicated. On the trip back, my partner and I are doing a lot of work. We insert arterial lines, we start vasoactive medications, we manage the blood pressure very strictly. The patient at one point raised her hand off the cot, grasping in the air. I took my free hand, I grabbed it, and I held her hand until the trip was over. Didn't mean a lot to me at the time. We dropped her off. She went to the waiting team in the ICU. But in post-trip reflection, it dawned on me that of the several hundred tasks I performed on that mission, the most important was grabbing her hand and holding it. Put yourself in her place. She was petrified. It was 2, 3 in the morning. She had neurological changes. She was given a devastating diagnosis. We just separated her from her family. She's in this machine going through the sky at 200 miles an hour at night. It's loud. It vibrates a lot. She was scared. And the most important care I could provide was holding her hand. Now, that'll come as a shock to my daughters and my current past students who think I don't have a heart. But if you really think about it, that was the most important intervention I could provide her at the time, right? So we're going to focus on that conceptually as we move through the subsequent slides here. It really begs the question, though, of what is the basic elements of us as humans in this new age of technology, right? You can see a picture here. It's my youngest daughter in her early months of life being held by her ailing grandmother in her last months of life. She had multiple sclerosis. And it probably pained her to hold her granddaughter, but she wouldn't want to be anywhere else but there, right? So it really begs the question, as we move forward in this technological age, what activities will we insist on being performed by humans as we advance in this age? So think about that for a couple seconds. Normally I'd say a couple minutes, but they only gave me 12. But really, what activities will we insist on being performed by humans, particularly in healthcare? So this is a question I've asked my students for the last 8 or 9 years in a leadership course that I teach. When we cover the book called Humans Are Underrated, and the primary assertion of this text is that question. Now, if you put yourself in the place of my graduate students who are largely in their 20s and they're budding romantic relationships or early marriages, you can only imagine the answers they first give me when I ask that question. But when we move beyond those hedonistic answers and focus particularly on healthcare, they all come to the conclusion, a majority of them do, every year, I've been asking them this for 8 or 9 years now, that they want their healthcare provided by a human, full well recognizing the trade-off that if they were provided a machine that was 100% accurate all the time, they'd rather have a human provide them less reliable care. So at face value, it seems irrational. We also know that we're irrational beings, right? So I asked the same question of Microsoft's Copilot AI, and you can see here that it listed healthcare and personal care as one of those things we'd like to be performed by humans for the obvious reasons of empathy, compassion, and personal connection, right? I'll point out to you very quickly, though, that there is a number 1 reference beside that to the article titled here that was written by a human. But we also know that we are more accepting of technology in this space, particularly with the pandemic. We've had a lot of transition to virtual care. And we see here evidence of us accepting that care and actually enjoying that care, particularly for its convenience. But as my colleagues have mentioned, this also brings up a lot of concerns. As an educator particularly, I see a hijacking of the learning process. You now have one of the most powerful computers in your pocket. You can ask it any questions. Notice I said ask it, not type into it anymore, right? Children are now starting to ask, why do I need to learn to read if I can just ask it questions, right? Any answer you want that we mostly think are accurate, which is a different issue that's already been pointed out, all right? We're hijacking the learning experience. We know to learn something, you need to be exposed to it multiple times. You need to create or establish those neuronal connections and then solidify them over time to know something, right? We're bypassing that now. Significant concern. And per the previous presentations, we also have evidence that we have significant shortages, both at a faculty level and at a staffing level in healthcare settings. And as we think about those shortages, the most common theme we hear all the time and we discuss technology in the workplace is displacing humans and the concern for that. But as we've already seen in the previous presentation, and what I've shown in the previous slide is, we already don't have enough people to do all the roles we need fulfilled to provide safe and competent care. So I'd suggest that we must adopt this technology and develop it to meet that need that we're trying to accomplish. And I'm hopeful because we already have some successful implementations in a hospital setting. This is a picture here of what we call tele-ICU, where we have cameras in all of our community health system ICUs that are linked with the EHR data, so think laboratory results, vital signs, running on the background in real time, where several centralized care providers, particularly on night shifts and weekends, can oversee all the care of every ICU patient in the Cleveland Clinic Health System. And that's important because we usually don't have providers staffing those units, like I said, on nights or weekends, right? And it can identify in the background patients that are trending in the wrong directions. So think early sepsis warning signals, okay? So we can intervene earlier. Or they can literally talk to the staff in real time. This works well for our team when we're dispatched for a patient in respiratory distress. The nurse practitioner can talk the local team there through intubating the patient prior to our arrival, instead of waiting for us to arrive, which is the most common thing. Oh, thank God you're here. We were waiting for you. You shouldn't have been waiting, right? So we have evidence that this has decreased interhospital transfers, it's improved length of stay, and mortality in the hospital settings. There's still some development work to be done here, but this is a successful implementation. We also have the new emerging practice of what's called virtual nursing. I didn't even know about this until my students started educating me on this. Some of the graduate classes I teach, I have students throughout the country that are coming to get their DNP degree. And they talked about implementing virtual nursing. It's exactly as you see here, where you can have a remote nurse provide some of these services listed on the slide here. I won't go through all of them in consideration of time, but you can imagine how useful this might be for nurses that may be physically abled, that they can sit at a desk and take care of many patients. I also think it's a benefit to have a few nurses doing really good discharge education, because we know how important that is for readmissions and the success of their discharge, that they can actually become expert at it versus doing a bunch of tasks that take a lot of their time. As we develop these systems, we have the tele-ICU, we can employ these new models that can do things that are largely observation intensive, and I have some of those listed here, right? And a great example of this is out of Stanford, where they're using an Alexa-like device to record the patient encounter, to make an accurate reflection of that so you don't have to have the charting burden post-encounter. Right now, you can imagine the problems that come up with that, but they're working on that as well, and I'll cover one of those here in a second. But again, it goes back to the beginning. It's identifying and enhancing the ability to focus on meaningful interactions with patients, which is, again, our concern as we implement this new technology. Per our previous presentations as well, we have to remain vigilant, though, right? Virtual nursing is a largely new process. So what are the policy implications of this? What are the practice implications of this? What do the patients think about it? Do we feel like Big Brother is watching us our entire stay as we're laying in the bed? Or are we comforted because someone is watching us our entire stay, right? You see the trade-off there. And the answer is probably somewhere in the middle. We know we need to validate these tools because what most of us will tell you is a model developed in one setting only works in that setting. In the instant you employ it in a different data set, hopefully a bigger data set, right, it doesn't always work well. And then we also know that when we test these models, it makes things up. And if you understand the background large language models that they're based on, you understand perfectly why that happens, okay? But ultimately, I'm hopeful. I'm hopeful that if we continue to carefully develop and employ these systems in a clinical setting, we'll be able to address our most pressing issues, not the least being unburdening our clinical personnel from the tasks that take up most of their time to actually provide the care that we strive for the most in a healthcare encounter, which is the comforting presence of an individual, particularly when you need a hand in your biggest time of need. Thank you. Second. Oh, okay. Let me grab some water quick.
Thank you so much. I would like to invite our presenters to come up front so that we can have a question and answer time.
Well, you started it off, so well.
Okay, thank you. If you'll speak into the microphone.
So for Dr. Parwani, you were saying that when you trained that there were 5 different kinds of kidney cancers and now there's 100 different kinds. With regard to the kind of histologic studies that are done these days, how much has that changed in terms of, it's great how you showed us how you can see pictorially everything and look, they're amazing pictures, but in terms of like the different kinds of.
Yeah, so great question. So we still use H&E as a basic stain to start things off, where a pathologist or a resident or a medical student looks at it and they make a differential diagnosis. And then, but today we have more testing that's available to us. Immunostains, molecular testing, FISH, that was not available 10 years ago. So simply speaking, we look at kidney tumors and there are three kinds, white, pink, and blue. And then we look at the morphology, look at the patient's age, and then we do additional tests. So the complexity of the test has changed over the last decade. But we still use H&E as a starting point, just like we did hundreds of years ago.
Additional question to Dr. Parwani, and then based on what Dr. Best told us about.
Yeah, so the question was, is there a problem with image distortion? Yeah, true, that is happening today, but one of the things that when we build AI algorithms is we normalize the stains. We take pixels and patches from those images and use it to train AI and also use it for our diagnostic processes. So as pathologists, we are actually pretty good with looking at slides with artifacts and even in spite of that making a diagnosis. So the same thing applies for AI. So image distortion is something that needs to be addressed, but there are ways today with technology to overcome those hurdles.
Okay, in the front.
I'm a retired diagnostic radiologist, so I'm invariably asked, well, what do you think is the impact of AI on radiology? And I think what they're really asking me, but don't want to ask, do you think AI is going to replace radiologists? So I think I have the answer, at least in nursing and dentistry, so I'll ask our pathologists, do you have fear of being replaced by a machine?
So I think just like we talked about radiology and nursing, same thing with radiology. We still have a long way to go. There are many algorithms available in radiology today. Radiology went digital, like 20 years before pathology. We still have algorithms which are not even FDA certified or FDA approved, but they're getting very, very close to pathology. So in the future, I'm predicting, this is my opinion, it's not based on anyone's recommendations, there will be no pathology or radiology. It's just going to be diagnostic medicine. All of us will work together in diagnostic medicine, because the images that I showed you, we are getting very close to radiology from pathology, and radiology is getting very close to pathology at the molecular level. So AI will impact all areas of diagnostic medicine in the future, and some of them will be lab-developed tests, some of them will be self-validated decision support tools, some of them will be billable clinical tests in the future.
I have just two concerns. I was a nurse and then graduated from Case Western in 1984, so our learning was always hands-on. We had no computers, nothing. So two questions. Will our distinguished guests here and those entities, nursing, medicine, dentistry, will they be part of the determination of whether Okay. Are clinicians going to be part of the process in determining whether these algorithms are valid, or will the companies take over and say, actually, this is valid, and the dentists are going to use it, the nurses are going to use it, medicine is going to use it? So that's a big concern I have. Who determines the validity? And number two, which was said, if a nurse if the AI is telling the nurse that your patient's in trouble because they're going into shock, so I go and see that patient, I didn't learn how to determine that that patient was in shock because I never learned to watch myself at the bedside, tachycardia, hypotension, change in pulses, color, poor mentation, all the things we learned at. That is not part of our education because now we have AI. As you said, Dr. Runny, that's going to be a problem for medicine.
So to your first point, I think it depends on the setting, on the supremacy of who gets to validate, right? Large health systems like Cleveland Clinic have business intelligence departments where we develop these models in-house with our own health system data, and then validated by the users on the user end, right, as being useful or not. Some evidence of that was the tele-ICU data that I alluded to earlier. But in smaller settings, you probably don't have the bandwidth, the personnel, or the budgets to do that development, right? So Cleveland Clinic is spinning off some of that technology. So contractually providing tele-ICU to other settings, knowing how complicated it is to develop. To your second point, I think there's a common thread through the three presentations of, I think what we're really getting at is this threat on expertise, right? I know in my training, when I asked an expert provider, how did you know that? Because I know as I developed my flight nurse practice, I could walk into a bedside anywhere and in less than half a second know how my next hour is going to go. And it'd literally go like this, oh shit, this is gonna be a lot of work. But I noticed 200 different cues in that second that pattern recognition over time tells me what I need to do, right? So is that a threat of being lost? Yeah, I mean, I was making the argument even prior to that circumstance that we're not even learning those cues and patterns, right? So now it's probably not going to be that dramatic, right? It will work itself out, but certainly human in the loop has to be our consideration for this, and it being an adjunct in providing care. It can't be the sole focus because they're wrong too. The machines are wrong too sometimes.
Thank you.
So just as a follow-up, I think if I think about medical education today, dentistry, nursing, I think this is a call to action to all the programs to put something in your curriculum for the future students or the current students, or both, which is to address this issue of AI and its implication in your practice today. I think this is important because if we don't, like when I was a resident, I got 1 hour lecture on how to turn on and turn off a computer.
I will pose you a more catastrophic dystopian scenario. The weather is changing, right? Those of us that believe in climate change. You're very dependent on AI. Your electricity goes down. You no longer have access to your crutch. And if you can't think on the fly because of experience, your patient is screwed and you're screwed because you'll be sued. Trust me, it's the way it works. So you need to learn it.
There was a question there.
Turn text around and following up on the previous question, comments or thoughts directed to Dr. Best initially. What are your thoughts on insurance companies like Delta Dental using Novo Dental in Michigan to look at every single claim and using AI for doing quality checks on the practitioners?
I'm going to give you 2 answers. One is, you got Big Brother. You can't do what I did. What I did is, and I will give you the scenario, I used to be in the Sloan Kettering pediatric dentist for 12 years. So every Monday I would go to the pediatric floor at Sloan Kettering, treat cancer kids. As a courtesy to my attendings, I took their insurance. Now I practiced in the middle of Manhattan, so my middle class patients anywhere else in America are rich. That's just the way it is. 2 patients went up to the front desk at the same time. One was a Sloan Kettering attending's wife, and one was a non-attending's wife. And when the non-attending's wife saw that the attending's wife, we were taking her insurance, She went ballistic. And the way I solved it was, you know what? I don't take it as of tomorrow. I stopped. So for 40 years, I never took insurance. I gave them the paperwork that they could do because I didn't want to have to deal with that crap, with the insurance companies dictating my treatment. It's the same reason why if a parent came in, and we used to have the parents in the room, if the parents, how do I put this politely? Parents who are successful think that their expertise transcends their area of specialty, okay? And the two things I can't stand are iPhones, because people walk the streets of Manhattan looking at their phone and not looking where they're going, and I don't move, so they bump into me. And they Google everything, and they don't know what is legitimate fact and what's not. If you ask me that question, usually in a very subtle way, I force you out of the practice.
Any other, we have one more here. That'll be our last question.
Do this.
Possibly, but here's the problem. They've already got FDA clearance. So the cat, what is it? The cat is out of the bag, whatever that expression is. They're already selling it today. You can buy it today. So what we do in the future, I mean, in 10 years from now, maybe AI diagnosis of interproximal decay will be accurate, but people are going to be using it between now and 10 years from now. And all I can do at the 3 schools that I teach in is sound the alarm and try to instill on the residents. I don't teach dental students, I only teach pediatric dental residents. Use your brain. God gave you a brain and gave you a set of eyes. Read journals. Don't believe what your friends tell you, and do the hard work. Go on when I was a resident writing my master's thesis, you had to walk to that bloody library and find the books in the card catalog, right? All the journals. Now you pour yourself a glass of wine, turn around and turn on your computer, and they still don't do that. I hate to dump on people, but their worth ethic needs work. That's just reality.
Thank you so much, everyone. Oh, you had one more? Okay, is everyone okay with? Oh, okay. Well, we won't stop you.
With all this wonderful technology that we got, why last night did it take me 37 minutes to get the gate open at the P1 parking lot?
Good question. You're right.
That's funny.
They're the glitches.
That's depressing.
Well, thank you so much, and I hope that you have a wonderful weekend.